Our presenter today is Rhonda Whiteman. Rhonda is the Stroke Best Practices Clinical Nurse Specialist at Hamilton Health Sciences. She supports teams within Hamilton Health Sciences and the Central South Ontario Stroke Network. And it's to implement best practices for stroke care across the continuum. Welcome, Rhonda.
Thank you, Tina. Really happy to be here to present sort of 6 to 24 hour LAMS positive, our final case study for today. I'm really going to talk a bit about the evidence for stroke endovascular therapy within the 6 to 24 hour window. We'll talk about our hospital's acute stroke 6 to 24 hour protocol. We'll talk about how does that fit with our current paramedic prompt card, and then talk about some of the work that we're doing moving forward in partnership with CPR and changes we may see as we move forward. So when we look at stroke endovascular therapy in the 6 to 24 hour window, in 2018, two trials were released. The Dawn trial that looked at thrombectomy after stroke in the 6 to 24 hour window, and the Diffuse 3 trial that looked at thrombectomy for stroke at the 6 to 16 hour window. The big difference with these two trials versus the previous endovascular trials that had been done is how they selected patients. Both of these trials selected patients using CT perfusion imaging. What they looked at is patients with anterior cerebral artery or middle cerebral artery occlusion, patients who were independent prior to their stroke, had an NIH greater than 6, so a pretty significant stroke, and had a clinical mismatch between the stroke severity and the size of infarct on CT with the rapid software. And essentially what that means is the patient has a pretty significant disability, stroke deficit, but if you look at the imaging, they have very low areas of infarct in the brain. And so what the CT perfusion does is actually assess the cerebral blood supply to look for areas of reduced cerebral infarct in the brain. It provides these very simple, easy to interpret maps, which quantify that blood flow and volumes to really identify patients who are eligible. The rapid automated software is a medical imaging package utilizing AI that really takes the thousands of raw images of the CT perfusion and creates these very simple maps to really allow for very timely interpretation of imaging across various CT scans to help identify patients eligible for endovascular treatment. So what did these two trials find as they were going? So what you can see is though both of the trials were looking at 16 and to 24 hours, most of the patients that were eligible and were identified were presenting between 10 and a half and 12 hours after their onset or last known well. Only about 10 to 35% of patients were witnessed onset of stroke. 50 to 63% were patients who woke up with their stroke symptoms, so we don't know what time the stroke happened. These were big stroke deficits with an NIH of 16. Essentially, that means that they have complete hemisphere deficit. An NIH of 16 is essentially someone, if it's in the left hemisphere, they have face, flaccid arm, flaccid leg hemiparesis, they have aphasia. If it's in the right hemisphere, again, they have face, arm, and leg, significant hemiplegia. They have visual field deficits. If it's on the right hemisphere, they'll have neglect. But what they know is the infarct volume on the perfusion was very small, between 8 to 20 mLs of blood. And if you think about a complete hemisphere is about 150 mLs that you would look at. What both of these trials found is that patients who underwent endovascular therapy 28 to 35% of those patients compared to control were functionally independent after their stroke. So again, very similar outcomes to what we saw with endovascular therapy in the 0 to 6 hour window, and allowed us to really identify patients who were highly selected, who may be eligible in the expanded window. So when these trials were released, there was a lot of concern about would we be treating hundreds and hundreds of patients with endovascular therapy in the expanded window. So Dr. Joven, who was one of the primary investigators of the DAWN trial, worked with one of his colleagues to do a retrospective review to identify how many patients would we be seeing and might be eligible based on the results of these trials. And so what they did is they found 30% of patients arrived to hospital within the 6 to 24-hour window. So 70% of patients are arriving in that early window. And so I used it based on our volumes of ischemic stroke patients in Central South to give you sort of a bit of numbers to quantify. So there's just over 2,200 ischemic stroke patients in our region. So that means about 700 patients are presenting in the 6 to 24-hour window. What we know and what they found is 10% of that 30% had an NIH greater than 6. So we know sometimes when patients present to hospital later, they may have milder symptoms. So about 10% of those patients had more severe deficits. So about 234 patients. What they did is of those 234 patients, they put them through the CT perfusion, CT perfusion, CT angiogram. What they found is only between 1.1 and 2.7% of these cases would either meet both the DAWN and diffuse 3 criteria, or 2.7 would meet either the DAWN or the diffuse 3 criteria. And so of that 700 patients who are presenting to hospital within that 6 to 24-hour, what we're seeing is about 26 to 63% of 63 patients are actually then eligible for endovascular treatment. And so really the way we identify that eligibility is with that advanced perfusion. And so what we know is we have to screen a lot of patients to identify those eligible for EVT in the late window. And so when we looked at these trials, we knew we needed to be able to offer endovascular therapy in the 6 to 24-hour window to our patients within our region. And so, as you know, this is our Central South region with the Regional Stroke Center at the Hamilton General and our 5 thrombolysis centers, Niagara Health, the Niagara Falls site, Brantford General, Grand River Hospital, Guelph General, and Joseph Brant. So what we did is we implemented the CT Perfusion Rapid software at all of these acute centers in our region. We started in 2019, and so remember these trials were released in January of 2018. By December of 2018, we had approval to move forward with implementation in our region. We implemented at the Hamilton General of June of 2019, and between July to January 2020, we had regional implementation of this advanced imaging software across our region. And we were the first region in Canada to implement this at all of our entire network. So again, as you know, when we looked at our acute stroke window, so recognize that in 2019, that's when we implemented the window. So let's look at a case. So we have a 77-year-old female who lived alone, was previously independent, who was taken to hospital by ambulance. Patient was talking to her family yesterday at 1900 hours. Her daughter-in-law found the patient on the floor at 1300 the next day, and dinner was still sitting on the table. Patient presented with slurred speech, word-finding difficulties, right facial droop, right arm weakness, AFib on the monitor, and was known to be on Xarelto. In this situation, the patient's last known well would have been 1900 hours when the family was speaking to them on the phone. So our paramedic prompt card in 2018 looked at patients in March of 2018. The provincial paramedic prompt card changed to have last known well up to 6 hours to allow patients to bypass to designated stroke centers. So in our region, that could either be our regional stroke center at the General, our district stroke centers at Brantford General, Grand River Hospital, or Niagara Health, the Niagara Falls site, or to our two telestroke sites at Guelph General and Joseph Brant Hospital. So at the time, we really wanted to still identify patients in the expanded window who may be presenting at any of our hospitals, so either our thrombolysis hospitals or our community hospitals in the expanded window. And so what we implemented in 2019 as we were rolling out our protocols was our Act Fast protocol. And so again, we know in the ED, the triage nurses are screening patients using that FAST sign. If they were in the 6 hour window, they'd follow their 6 hour protocol. If they were last known well in the 6 to 24 hour window, then they would be triaged as a CTAS 2. The EDMD would be immediately notified. The EDMD would assess their baseline functional status just to ensure that they were not wheelchair bound, bed bound, or had severe dementia. And the physician would do an ACT FAST screen, and I'll talk about what that is in a minute. If they were at our thrombolysis centers, then the patient would go on to advanced imaging, so a CT perfusion CTA. If it was at Greater Niagara General or the Hamilton General, they'd undergo the imaging and then activate the team. If it's at our other sites, our Brantford General, Guelph General, Grand River Hospital, and Joseph Brant, they would undergo the advanced imaging and engage in our telestroke sites. If it was at any of our community hospitals, either in sort of the Hamilton catchment or Brant Haldeman, Norfolk, Wellington County, and Niagara at the other Niagara sites, they would be transferred to our closest stroke site for the advanced imaging. If the advanced imaging is positive, then it became a stroke protocol. What you can see is the ACFAS screening is really determining that severity of deficit. So in this situation, you can see we're looking for A is arm. Is there one-sided weakness? So really positioning their arms up at 45 degrees with their elbows straight. It's positive if one arm drifts, they're uncooperative, or they can't follow commands. If the right side is weak, again, then we're looking at C, chat. We're looking to see if there's a severe language deficit. We're asking the patient to repeat. You can't teach an old dog new tricks, or to perform simple tasks. Make a fist, open and close your eyes. It's a positive test if the patient is mute, speaks incomprehensibly, or unable to follow simple commands. If the left arm is weak, we're really looking for either is there a gaze preference or is there a tap? So we're looking at T for tap. Here, similar to what I said in the anterior circulation slide, we're looking to see is do they have a consistent gaze to the right? So do their eyes consistently point to the right side? You want to stand on the right side and stand on the patient's left side and call their name. It's a positive test if they consistently gaze to the right. Alternatively, you can tap the patient's left shoulder and ask and call their name. It's a positive test if the patient doesn't quickly turn their head and eyes to you or neglects their left side. So if we go back to our case, and this was a recent case we had, patient was triaged as a CTAS 2 at Jurvinsky and was seen by the EDMD. The EDMD found that the patient was ACT FAST positive, notified the stroke neurologist at the General, and the patient was transferred code 4 to the Hamilton General. At the General, after a quick assessment, the patient underwent CT perfusion rapid, and a CTA. Here you can see a result of the imaging. So here you can see that the CT scan really isn't showing much of an infarct. The CT angiogram, you're seeing a bit of an abrupt cutoff in the left middle cerebral artery. So there's a clot in the left middle cerebral artery. And what you can see with the perfusion is there actually is really no area of decreased, significantly decreased or infarcted brain showing up in pink, but there is a significant area of viable brain tissue being shown here. So when we look at the patient presented with new onset of aphasia and right-sided weakness. The NIH was 17. So as you can see with the NIH, an NIH between 16 to 20, which is what most of the late window trials looked at, and most of the patients we see in the late window, these are moderate to severe strokes. These are obvious stroke symptoms. I often say neither of my sons are in healthcare, but by just listening to their mother talk about stroke, talk about the warning signs of stroke, they'd be able to identify that this patient was having a significant stroke. Patient underwent successful endovascular therapy for right middle cerebral artery occlusion with one pass. Patient was discharged to inpatient rehab 4 days after being admitted to hospital with a right facial droop, right leg weak, right leg drift, and slurred speech. So an NIH of 3 or a minor stroke deficits. Again, remembering EVT is for our worst of our worst strokes. So patient had a remarkable recovery. So when we look at where we're at currently with sort of our pre-hospital and hospital protocols, as we know, March of 2023, the paramedics prompt card was changed to have the LAMS to be done for all possible probable strokes presenting within 24 hours of stroke symptom onset. If their LAMS is greater than or equal to 4, it's classified as a CTAS 2, and there needs to be a patch to the receiving hospital that the patient is large vessel occlusion, either positive or negative. Patients presenting within 6 hours would be taken to the closest stroke center. Those outside of the 6 hour are taken to the closest hospital. Certainly, we have not changed sort of our ACT fast screening that we're doing at our hospital. And so by having the heads up with the paramedics that there's a large vessel occlusion clinical screen, positive or negative en route, really will help to quickly implement and evaluate their 6 to 24 hour protocol and facilitate transfer to the closest stroke center for advanced imaging. You may say, well, why are we not bypassing and changing and going directly to the closest stroke center that have the advanced imaging in the region? Again, provincially, the decision was made not to change the bypass and destination protocol. In our region, we're working very closely with the CPR, the base hospital program, to really look at and to understand what we're doing. So that, again, we can move forward and understand the volume of positive LAMS in the expended window to really help inform system planning. We don't have a good sense of, of all of the stroke protocols. How many stroke protocols are we seeing in the expanded window? And how many of those are LAMS 4 or 5? If it's 100, I'll use the example, just pulling a number out of the air. If it's 100 stroke protocols that we see in a particular area, is it 30% of those are, 30 of those are in the expanded window? And, is it 10% of those that we're seeing that are LAMS positive? Or conversely, of 100, is it 70% that are in the late window? And how many of those are going forward? So we're working very closely with LAMS, looking at the EPCRs to look at LAMS positive in the expanded window, and also those within the 6 hour window to really inform and understand system planning. really also then to also look at possible changes to local destination protocols based on that and having helping that to inform and discuss sort of what this looks like as we move forward with sort of getting access to that advanced imaging in the 6 to 24-hour window. So more to come with that as we move forward. Thank you very much.